Welcome, and thank you for standing by. At this time, all participants are in a listen-only mode. To ask a question during the question and answer session, please press star then one on your touch-tone phone. Today's conference is being recorded. If you have any objections, you may disconnect. Now I'd like to turn the call over to Dr. Chelsea Booth. Ma'am, you may begin.
Thank you very much, and good afternoon, everyone. As our operator said, I'm Chelsea Booth, Public Health Advisor in the Suicide Prevention Branch of the Substance Abuse and Mental Health Services Administration. We're delighted to be hosting the second webinar about suicide and intimate partner violence. The first webinar took place on September 11th and is archived on the SAMHSA webinar page of sprc.org. We think this is a crucial topic for discussion for many reasons. Suicide and intimate partner violence are each one of the major causes of death and injury in the United States. And reducing suicide and intimate partner violence are major public policy priorities. There hasn't been enough interaction between the two fields, and we really hope these webinars and our subsequent collaborations will help us all to do a better job of preventing suicide and intimate partner violence. So we have a wonderful slate of presenters today, and their presentations will complement those in the first webinar. So we'll hold all questions until the end. But as the presentations are going on, please feel free to either jot down your questions to ask verbally at the end, or you can use the Q&A box at the top of your screen. You'll see a bar, and it just says Q&A, and if you click on that, you can type in a question, and I will ask our presenters those at the very end. So our first presenter is Dr. Marylouise Kelley, Director of the Family Violence Division of the U.S. Department of Health and Human Services Administration for Children, Youth, and Families. Dr. Kelley administers the Family Violence Prevention and Services Act program, the primary federal funding source for states, territories, and tribes dedicated to the support of shelter and supportive services for victims of domestic violence and their children. The program also includes the National Domestic Violence Hotline and a network of national resource centers and culturally specific institutes and discretionary grant programs that address domestic violence. Dr. Kelley began working in the field of domestic violence and sexual assault services in 1983. Her career spans working as a victim advocate in a community-based shelter and rape crisis center to managing national programs addressing sexual assault, domestic violence, and child abuse. She has over 25 years of experience managing diverse programs including domestic violence, sexual assault, foster care, legal services, health care, substance abuse services, immigration and refugee services, and a network of family centers. So Dr. Kelley, we are delighted to have you here today and are ready for you to start.
All right. Thank you very much, Chelsea. And I want to thank my colleagues at the SAMHSA Division of Suicide Prevention for hosting these webinars. We are very pleased to participate, really got a lot out of the first webinar on September 11th, and look forward to our continued work together. I'm going to talk a little bit about the domestic violence services that we support across the country and how we see that linking with suicide prevention and mental health efforts. And then we'll pass it off to my esteemed colleagues to talk in more detail about this work. Next slide, please. Thank you. The Family Violence Prevention and Services Act funds core crisis and intervention services for the safety of victims of domestic violence and their families, and that reaches a network of more than 1,600 community-based shelters and 1,100 non-residential services that provide safe housing, crisis response, advocacy, legal assistance, counseling, safety planning, support groups for 1.3 million adults, youth, and children each year. So pretty much in every major community in the country, you're going to find domestic violence services. In addition, in each state, a state domestic violence coalition will coordinate and provide TA for the providers in that state. We reach over 220 tribes, and at the national level, support the National Domestic Violence Hotline and a network of national and special issue resource centers. Next slide, please. Now, these services are widespread and comprehensive because the need is very clear. According to the CDC's National Intimate Partner and Sexual Violence Survey, 3 in 10 women and 1 in 10 men have experienced rape, physical violence, or stalking by an intimate partner. And given this high prevalence of violence, service providers are struggling to meet the needs of survivors, particularly in an ever-tightening fiscal environment. In a 24-hour census conducted by the National Network to End Domestic Violence, they do this each September, they found that on one day in September of 2012, over 35,000 victims of domestic violence and their children were in emergency shelter or transitional housing programs. But at the same time, those programs had to deny over 10,000 requests for services because they were over capacity. And 65% of those requests were requests for shelter. So we have a very large but overburdened network of support services to meet the needs of victims of domestic violence. Now, I will note that in addition to the 35,000 people served in shelter, over 29,000 survivors and their children receive services in non-residential services. So domestic violence programs are moving beyond shelter and provide a significant amount of other types of supportive services, including mental health services. 83% of the domestic violence programs reported that throughout the year they provide or link survivors to mental health services. Next slide, please. Now, there are many challenges to the well-being of survivors that contribute to their risk for suicide or attempted suicide. First, it must be recognized that many domestic violence survivors are still under threat of ongoing abuse or stalking, which not only directly impacts their physical and psychological safety, but also how they will respond to treatment and interventions. And of course, experiencing childhood trauma or severe long-standing abuse as an adult is not only a risk factor for repeat victimization later in life, it can also lead survivors to develop harmful coping mechanisms, including suicide attempts or self-harm. We're also talking about people who are really in desperate circumstances. Most women who come to domestic violence shelters do so as a last resort. In a multi-state study of domestic violence shelter experiences, where we talked with survivors about their experiences, they reported that they came to shelter to avoid a variety of impossible circumstances, such as becoming homeless, losing everything, including their children. They came to escape continued abuse or risk of death at the hands of their abusers. And they came to avoid taking drastic actions such as suicide or partner homicide to stop the abuse. So we're talking about people who are at a very rough time in their life coming into a very stressful setting such as congregate living for those who come to a shelter. Other challenges that survivors face, we are also looking at, as I mentioned, the National Intimate Partner and Sexual Violence Survey found a high rate of experiences of intimate partner violence among women. And in addition, they noted that 63% of female victims of intimate partner violence experienced at least one symptom of post-traumatic stress disorder. And we also know that other mental health conditions, such as chronic depression, are more common among survivors. And, of course, we'll hear more about that from Dr. Warshaw shortly. I also want to mention that threats of suicide are, of course, a form of control by the abuser. And so while these challenges that I mentioned can contribute to a survivor's vulnerability, the threat of suicide by the abuser is sometimes used to control or manipulate their partner. And, of course, an additional risk is the risk of suicide homicide. In the 2011 report by the Violence Policy Center that tracked murder-suicides reported by the media, they found that over a 6-month period that 72% of all murder-suicides involved an intimate partner, and of these, 94% were females killed by their intimate partners. Now, in terms of addressing the intersection between intimate partner violence and suicide, in addition to domestic violence advocates paying attention to the counseling, therapy, or referrals needed to reach mental health providers, doing good risk assessment and suicide prevention strategies. Also see some of the domestic violence service providers and the state domestic violence coalitions as great places for partnerships between the domestic violence field and suicide prevention and mental health fields. And as you can see from the map, we have some examples of some places where those partnerships are very strong. For instance, the North Carolina Domestic Violence Coalition partnered with the North Carolina Coalition Against Sexual Assault and the state's Office of Suicide Prevention to develop training and technical assistance for suicide prevention in the context of healthy sexuality and relationships. Several state domestic violence coalitions are involved in statewide fatality reviews, such as Kansas, state of Washington, where Jake Fawcett from the Washington Coalition Against Domestic Violence spoke in our last session about the things they've learned from their statewide domestic violence fatality reviews. And in Georgia, the Domestic Violence Coalition has coordinated a statewide fatality review, and that informed their development of draft protocols for advocates to screen for suicide risk among survivors and assess the risk of suicide threats among perpetrators. So state domestic violence coalitions can be a great place for partnerships to be fostered around training and technical assistance around the overlap between these two issues. Next slide, please. So as evidenced by the work of the coalitions and the programs, the domestic violence field recognizes the impact that mental health services can have in transforming and healing survivors. There is a huge demand among advocates for information about suicide and self-harm. And while there is an increased awareness among advocates on the need to screen for suicidality, additional cross-training among these fields would certainly be helpful. In addition, I just wanted to talk about the role of the National Domestic Violence Hotline. For the entire year, the National Domestic Violence Hotline screens nearly 23,000 calls each month. So for the year of 2012, we asked them to look at their call experience, and they found that nearly 1,000 calls, 977 calls, they fielded in which the survivor on the other end of the line self-identified as having suicidal thoughts or ideation. This was an 11% increase in callers identified as suicidal in 2011. However, we know that there are many more callers at risk for suicide who do not self-identify. So technical assistance and training from mental health experts is much needed, and the hotline is working really closely. And a great example of a great new partnership, they're working with Dr. Kate Cerulli at Rochester University. And Dr. Cerulli, and I believe she mentioned this on the call on the 11th, will be conducting an on-site training with hotline staff this November to identify what words a survivor might use to indicate suicidal thoughts. And the hotline staff will then update the computer programming codes with these keywords so electronic response the field advocates use to record their calls will include additional information on how to support callers who are feeling that way. So this important initiative is only a first step. With increased awareness of suicide risk and improved capacity of the domestic violence field to screen for suicidality among survivors, there may be additional demands on mental health services. And of course, and that will of course go both ways. As each field becomes more aware of the intersection of these two issues, we may be seeing additional need for partnership and additional need for cross referrals. So some of the steps that we are taking to address the serious mental health concerns and trauma responses among victims of domestic violence fall in the hands of and the leadership of Dr. Carole Warshaw at the National Center for Domestic Violence, Trauma, and Mental Health. And Dr. Warshaw's center has been one of our national resource centers for several years, first starting as a project and developing into a national resource center. And there is great demand and great interest across the domestic violence network of services in improving their capacity to provide trauma-informed services. Dr. Warshaw has long been an advocate for the mental health of survivors, and she will speak along with her colleagues Patty Bland and I think Gwen Packard from National Indigenous Women's Resource Center will also join later on how to build the capacity of mental health professionals to respond to the unique needs of patients experiencing the effects of trauma, and in addition to the work that is being done with domestic violence advocates around understanding this important issue. So I'm going to turn now to Dr. Warshaw.
Well, thank you very much, Dr. Kelley. I think that was a really good presentation, and I look forward to hearing some of our participants' questions about what you do. So as Dr. Kelley mentioned, our next presenter is Dr. Carole Warshaw, Director of the National Center on Domestic Violence, Trauma, and Mental Health, and the Executive Director of the Domestic Violence and Mental Health Policy Initiative. Dr. Warshaw chaired the committee that wrote the AMA Guidelines on Domestic Violence and has served on the National Research Council Committee on the Assessment of Family Violence Interventions, the Family Violence and Abuse and Childhood Trauma Committees of the American Psychiatric Association, and the AMA National Advisory Council on Family Violence. She's also a member of the SAMHSA Advisory Committee on Women's Services. Dr. Warshaw speaks about domestic violence, trauma, mental health, and psychiatric disabilities both nationally and internationally, and has published numerous articles and chapters on these issues. She's also an adjunct professor in the Department of Psychiatry at the University of Illinois. So, Dr. Warshaw, welcome, and we're ready for you to start.
Thanks, Chelsea. Thanks, Marylouise. So Patty and I are here, and hopefully Gwen is on the line. What we're going to talk about is thinking about how to think about mental health treatment in the context of ongoing intimate partner violence, particularly when suicide is an issue, but in the broader framework, and some of the things that we need to consider. And what I'm going to do, since I have a fairly dense presentation, is to highlight the key elements of each of the slides, and then you'll have the access to the more comprehensive information when they're posted. Just to remind everyone of the definition of intimate partner violence and to highlight that it's an ongoing pattern of assaultive and coercive behaviors that are used to really establish power and control over another person with whom you're in an intimate relationship. And that through fear and intimidation, often through the threat of use of physical, sexual, and psychological violence, but that suicide threats are also used as tactics of control, which Marylouise, you already talked about. But I just want to highlight that when we're talking about suicide and intimate partner violence, and also to remember that battering occurs when a person actually believes that they're entitled to control another person. So it doesn't just exist, as a result of psychological trauma, but that there's really the social permission that allows us to go on. So that part of when we think about domestic violence and trauma in the same breath, we're also thinking about the social justice and social change component. So for those of you who do suicide prevention work, it's also thinking about what changes the conditions that create these threats to well-being in the first place. So why think about these issues together? Clearly, they're both causes of lethality. They both suicidality, suicide attempts, and intimate partner violence are also leading causes of morbidity and psychological harm. So just to look at these issues together, this was from a meta-analysis done by Jackie Golding. She had originally done one in 1999. She did another one with us in 2000. And you can see the high rates of depression and PTSD among women who are being abused by a partner in a variety of settings. And the data on suicidality back then, which has really been confirmed in more recent studies, was around 25%, 20%, around 1 in 5, and that's in the recent study that Kavanaugh study and Jackie Campbell, it was similar numbers. But in mental health settings, the number is much higher. So if you're working in a mental health setting and you're seeing someone who comes in who's with a suicide attempt, over half the time that person will be in an abusive relationship. So again, it's thinking about things from both sides. I also note that women who are involved in the legal system and courts, this is a study by Marianne Dutton, over 70% experience depression. So again, thinking about these issues contextually is part of what we want to emphasize in this conversation. Also, thinking specifically about intimate partner violence and suicide, this is partly the point of this webinar. We know that IPV increases women's risk for suicide. And that one study in a psychiatric inpatient unit, over 90% of women who were hospitalized after a suicide attempt reported current severe domestic violence. So think about that. How often do we think about that when we're doing mental health assessments? And we had done some work in Illinois with the state hospital system, psychiatric hospital, who had a SAMHSA transformation grant, and part of what the reducing seclusion and restraint was thinking about how to make services trauma-informed. And people were very aware that many of the people in mental health settings, in fact, the majority, had histories of abuse in childhood, but they hadn't yet thought, and this was quite a number of years ago, about ongoing current abuse and risk. Again, when we look at, and that comes up even when you think about who you involve in treatment. Thinking about community settings, you can see the numbers are still extraordinarily high, and there are people who've reported attempts, the differences between people who've experienced domestic violence or not, or who can seriously consider suicide. So the real question is, do we ask routinely about this? And I think we're all pretty in agreement that that's a critical issue. Later we'll talk about how to ask and what are the other things we want to know. But context also plays a role. The traumatic context, one is the duration and frequency and severity of abuse. Severity of abuse is associated with greater risk for suicide attempts. Marylouise, you talked about desperate circumstances. So all of the things that trap domestic violence, it keeps women isolated or individuals isolated and trapped. And that when social conditions contribute to that, it makes it much more desperate. Also, the types of abuse, there's some research that shows that experiencing sexual violence in the context of a domestic violence relationship, women who'd experienced sexual assault were over 5 times more likely to report threatening or attempting suicide within a 90-day period. This was work by McFarland and others. So again, thinking about many of the other factors that contribute to someone feeling suicidal or making suicide attempts, the cumulative burden of trauma, which we'll talk about a little more later, and the broader social context. So what are the things that keep people trapped that make it impossible to leave? We had done focus groups with one of the Asian women's shelters in Chicago many, many years ago, and advocates thought that, of course, women are depressed when they come in, but once they have access to safety and support, that they tend to feel better. But when they have to leave and no longer don't have access to resources or threatened with deportation, the depression comes back. So again, it's not just something inherent to the individual, not just something that's a result of the abuse, but also the social conditions make a difference too. We also know from studies, this is again Kavanaugh study that Jackie Campbell was involved in, that suicidality in the context of domestic violence not only is linked to depression and PTSD, which we tend to recognize, partner threats of suicide and homicide, chronic illness and disability, and substance use. So all of the things that we see as common effects of domestic violence are very much linked. And we also know at the same time that cessation of violence, social support, parenting support, and access to domestic violence advocacy do make a difference. So again, we're always thinking about where are the harms and what are the things that mitigate those effects. What are the things that we can all do? We also know that survivors experience multiple types of trauma. And we tend to think in the mental health field about individual trauma, the childhood victimization that increases the risk for abuse as an adolescent or an adult, and the coping strategies that people develop to survive the overwhelming emotional effects of abuse that may increase their risk for being harmed, like using self-cutting, self-harm, or using substances that then increase their risk for coercion and control. And also not learning that you have a right to protect yourself from harm or never having actually been able to. We know that dissociation that is one coping strategy and now is a new subtype of PTSD may place people at greater risk for abuse because they're not able to attend to cues from the environment. But we also think about collective trauma, and not just the trauma that people experience as individuals, but the historical, political, and cultural forms of trauma, immigration-related trauma that affect whole entire communities and affect them across generations. So when we're thinking about the cumulative burden of trauma that impacts suicide and suicidality, we need to think about collective solutions as well. The other thing to think about is that whatever someone's vulnerabilities are, abusers exploit these experiences. And so we talk about risk rather than vulnerability. It's not something, again, inherent to the person who's being abused, but something that abusers can get away with exploiting. And when we talk about resilience and protective factors, we also talk about community engagement and what kinds of solutions actually transform those conditions, not just individual solutions. This is just from a recent study, well, not so recent anymore, by Rees et al. And JAMA, looking at rates of mental disorders for women who are exposed to gender-based violence. And you can see the more types of gender-based violence you experience, the more likely you are to develop all the conditions we talked about, including suicide attempts. And those numbers are even higher than the numbers for domestic violence alone. At the same time, just to flip this around, that women who are seen in mental health and substance abuse settings are at greater risk for abuse. And the numbers here have actually stood up for many years. There are old studies and new studies that have the same numbers. But basically, you can see the prevalence rates of abuse and violence across the lifespan for women who are receiving mental health services are extraordinarily high. And therefore, really looking at all of these issues has to be part of our day-to-day work. When we think about women who experience substance abuse, this is one of those places where it's really clear that we can look both at the traumatic effects of abuse and the ongoing coercion and control. So women have higher rates of substance abuse when they've been victimized, but women in substance abuse treatment also have very high rates of victimization. And that up to 80% are victims of domestic violence. This is from Patty, one of your slides. We also know that self-medication is common, so that people's use of substances is often a way to manage the pain or the affect dysregulation that results from abuse and violence. But at the same time, survivors are often coerced into using or dealing by an abusive partner or prevented from abstaining. We'll talk about that in a little more detail in a few minutes. So why is this? Again, I talked earlier about risk versus vulnerability. And one of the things that's been very important to the domestic violence advocacy movement is the idea of perpetrator accountability and recognizing that unless we hold perpetrators accountable and recognize the things that they're doing in an ongoing way, we're not going to be able to help someone, particularly when we think about that in clinical settings. So we know that batterers use mental health and substance abuse issues to control their partners. And this is one of the things that I really hope you will take away, that they control medication, they control access to medication, they force their partners to take overdoses, then they have them committed, then they use that against them in a custody battle, they control their supply of drugs, coerce them into using, and coerce them into engaging in illegal activities. They often try to control treatment. So part of what they might say, she was out of control and I had to restrain her, and then the woman comes in with injuries and it's because she was using drugs or because she was out of control through suicidal, and we don't recognize that in fact this was a false allegation on the part of an abusive partner. So basically what happens is abusers undermine their partner's sanity, credibility, parenting, and recovery, and then use that against them when they try to get help. We recently did a study with the National Domestic Violence Hotline on what we call mental health coercion and substance abuse coercion. And the mental health coercion study, it was over 2,000, close to 3,000 participants. We asked 5 questions. One was, has your partner, ex-partner ever called you crazy or accused you of being crazy? And over 85% of the participants, it was over 2,000 callers, said yes. We asked, do you think your partner has ever deliberately done things to make you feel like you're going crazy or losing your mind? And over 73% said yes. We asked if your partner ever threatened to report to authorities that you're crazy to keep you from getting something you want, like custody or an order of protection, and over 50% said yes. And when we asked if people had sought help for any of these conditions from a clinical help, around 50% said yes, and we asked if their partner had tried to control treatment, they said yes. And so again, when we think about the work we do in mental health and substance abuse settings, similarly on the substance abuse coercion study, women were coerced into using, were afraid to call the police for help because their partner said they wouldn't believe you because you were using or you'd be arrested for being under the influence, that if they tried to get help, their partners also tried to discourage them or prevent them. And we had lots of stories about how that happened. So again, thinking about that role when we're thinking about mental health and substance abuse effects of domestic violence, we have to also think about the larger context. And why does this work? Sometimes reports of abuse are attributed to delusions. Symptoms of trauma are often misdiagnosed. The assumption that having any kind of mental illness or using substances precludes good parenting is rampant among judges in family court, and not recognizing that often symptoms of mental health symptoms and substance use is actually part of the abuse itself. But the real reason why this works is because of stigma, and people who abuse their partners play on that and manipulate systems based on stigma that we all carry. When you think about someone coming into an emergency room, and one person looks very well put together, and the person he or she's been abusing for years is acutely suicidal or is having psychotic symptoms, who are we going to believe, who are we going to take seriously, and who are we going to ask for collateral information? So it raises a lot of issues when we start to address abuse and violence and suicide. So again, abusers control their partner's ability to utilize resources, and trauma, the traumatic effects of abuse, can also affect survivors' access to resources, both in avoiding things that may be triggering, being reluctant to reach out for help when trust has continually been betrayed, and particularly for communities of color where the law enforcement and legal and criminal justice systems have been not sources of help, but have been sources of betrayal. So for survivors who are dealing with draconian immigration laws and being afraid to walk out of the house, or kids being afraid to go to school because they don't know if their parents are going to be there when they return, add layers of barriers to accessing services. So when we think about collaboration, we need to think about having the same goals, but we often have different focus, whether we're focusing on healing the consequences of abuse, facilitating recovery from substance use and abuse, or mobilizing resources to end the abuse, but clearly they're all critical. This slide comes from focus groups we've done with women many years ago, both in domestic violence shelters and in mental health and substance abuse settings. And just want to make some points. One is really being wary of abuser control of treatment. We just talked about how abusers try to control treatment and control access to treatment. For example, with medication, abusers may refuse to have their partners take it, may force them to take too much, may use that as a way to accuse them of being an addict, or may steal their medication and use it themselves. So there's a continuum of creative ways abusers use these issues against their partners. But in a recent article on suicide prevention that I was reading, the person was very aware of the link between intimate partner violence and suicide, and suggested screening and assessment and then referring to couples therapy and anger management, which we know is not safe for many, many survivors. It's not safe to talk about what's really happening without being retaliated against when you go home. So just to keep in mind as we start to take on these issues what the potential dangers are. And for women in mental health settings, both inpatient and outpatient, they said nobody talks to them about domestic violence, and they want access to resources in the community and within those settings. So what else do we need to keep in mind? When we think about PTSD in the context of domestic violence, obviously the trauma may not be post, and some of what we think of as symptoms may be an appropriate response to ongoing danger. So again, thinking about how we understand things from a clinical perspective and how we need to stretch to think about them when someone is continually under siege, whether it's from an abusive partner or from other social circumstances. So sometimes are we talking about someone being triggered, or are there real things happening in their life that are placing them in danger? Another way to reframe our thinking is looking at recognizing that domestic violence survivors make many attempts to stop the abuse, to reach out for help, to say if I change this or if I change that, maybe it'll stop. They may appear passive and compliant because that makes them safer, when in a setting where they're actually safe, that will not be how they are. And when they can't change things externally, we all try to manage the impact internally. And now we can say use dissociation rather than denial, which was a more pejorative way of talking about this, and self-medication, self-injury as ways to manage the feelings. But when none of those work, sometimes survivors use potentially lethal means of escape or efforts, and that's usually because nothing else is working, and that women when they do have access to other options, it makes a huge difference. So thinking about domestic violence and mental health and trauma together, we're looking at a very complex picture. We're looking at the direct effects of what abusers do to control and undermine their partner's mental health and sanity. There's the psychophysiological effects of trauma that we're all familiar with. There are literal survival strategies that hypervigilance may be keeping a woman out of the emergency room. There's the exacerbation of pre-existing mental health and substance abuse conditions and using that as a further tactic of control and way to abuse. The active undermining of a survivor's parenting, which is another critical component of abuse, and when women lose their kids, it puts them at greater risk for suicide. And then thinking about what are the things in people's communities and culture that actually undermine their ability to deal with abuse, and what are the things that actually really support them that they can draw on as sources of strength and resilience, and how do we deal with the social conditions that perpetuate all of this? So what are some of the things we need to keep in mind? How does understanding these issues help survivors? It helps us understand survivors' responses and context, both in a trauma context and an ongoing danger and coercive control context, and allows us to respond in more helpful and empathic ways. One way to think about what it means to be trauma-informed is that everything we do is designed to counteract the experience of abuse, what it feels like to be treated in a dehumanized, controlling, demeaning way, and then to mitigate and transform the effects of abuse. The other piece is understanding our own responses and their impact and the need for organizational support. This is something domestic violence programs around the country are doing, and as are mental health programs. And so when you think about working with someone who is dealing with such painful and frightening experiences, and particularly when they don't have a lot of options, and that's something that we need to sit with. It's something that we need supports to be able to stay emotionally connected and present so that our own needs to feel like we're being helpful don't end up becoming coercive or controlling or directive inadvertently. And this is just a review of what we mean by a combination of domestic violence and trauma-informed services. Again, it's combining services that respond to the impact of abuse as well as changing the conditions that perpetuate abuse. So some of the key elements to keep in mind, one is safety as a priority, and I'll talk about all of these in a minute. Respect, collaboration, empowerment, and choice, those are essential to domestic violence advocacy, they're essential to being trauma-informed, and they're essential to any kind of service that we provide regardless. And the other things I think we've already talked about. Partnering with DV advocates, again, is critical because there are many pieces as clinicians that we're very familiar with, but the safety planning and interfaces with all the other systems that survivors deal with, advocates have tremendous expertise in all of these areas, and it's very hard to do that work alone. Thinking about an integrated approach to safety, in a mental health context, particularly when we're talking about someone who's dealing with feelings of suicidality, we're talking about self-harm and then potentially harm to others. When we think about this in the context of ongoing trauma, we're thinking about wanting to minimize re-traumatizing people who've already experienced trauma and to help people gain perspective and new skills to manage potentially risky coping strategies. When we think about this in a substance abuse context, we're thinking about the increased risks that someone may face and the potentially lethal and medical effects. And then in a domestic violence context, we're talking about ongoing danger and coercion from a partner and the re-victimization that many survivors experience in dealing with other people and systems. And we also think about the broader social political context as well. So thinking about a couple things, like privacy and confidentiality are critical, and Maxine Harris talked about, when you're thinking about a trauma-informed approach, it may be very different from a DV-informed approach, and we have to consider them all layers that are important to consider. For example, in asking about domestic violence in healthcare settings, we want to be very clear that people have safety and privacy and confidentiality, that the abuser isn't hovering by the doorway or making sure that they're in the room with you, making sure that you're not using a translator, interpreter who is connected to the abuser, so that someone who's very professionally trained to understand the dynamics of domestic violence, and not asking an abuser for collateral information. We often do that when someone comes into an emergency room for a suicide attempt, and it's something that's really critical to keep in mind. Maxine talks about if you say, what you say here will stay between us in this room, it's confidential, that may be very terrifying to someone whose uncle said that to them when they were 5. So being in a closed room with a stranger in a position of authority may not feel safe to someone. So it's really thinking about safety in multiple ways. Again, holding perpetrators accountable, one of the critical things we want to keep in mind is recognizing that perpetrators may look much better put together than the person that they've been undermining, and to remember that when we're doing our assessments. And the other piece that survivors tell us is not focusing on helping women understand why they unconsciously, quote-unquote, chose to be abused, rather than addressing safety and why abusers can't get away with victimizing people who've experienced a lifetime of abuse. This is just to remind us that for anyone who's experienced abuse of power and violation in their lives, that will be very attuned to power dynamics, and we need to be very attuned to those as well as understanding our own ability to tolerate fear and uncertainty. So when we ask, how am I doing on time?
You're doing just fine.
Okay. So, again, we want to, every health and mental health setting, we want to routinely inquire about intimate partner violence. One of the things before the U.S. Preventive Services Task Force upgraded screening for domestic violence to a recommended level, it was like, well, and we wanted to use the term screening to make it more palatable to healthcare providers, but why would you not ask someone about what are the things that are happening in their lives that are affecting their health and mental health and well-being? Again, safety, we want to ask about safety not only when someone leaves, but also are they safe in the clinical setting? And is the person who's abusing them likely to return, and what do they want to do? Do they want to go with them? Do they want to hide? Do they have a protective order? So thinking about all of those kinds of things, as well as threats to safety that include suicide and homicide. So safety is a much bigger issue when we're talking about domestic violence. We also want to know about the history and pattern of abuse, including the ways that an abuser uses health and mental health and substance abuse coercion as ways to control their partner. Often asking about the history and pattern of abuse is a way to help someone actually see that in a safe way when they can't afford to see that when they leave because they just need to survive. I want to highlight traumatic brain injury and also impact on children. Survivors are very concerned about their children, and that's often a high priority and motivating factor and also a protective factor in terms of suicidality. Obviously, when someone starts to say the kids will be better off without me, that's a clear sign that things are escalating. And asking about other trauma, finding out, are there other things that have happened to you that may be affecting how you're feeling now is important, rather than going through a whole laundry list of many horrible things that may have happened, at least initially until you establish a relationship. The other thing is, doing this work is very strength-based, and when you're working with people who are suicidal, it's very anxiety-producing for us, and we often want to be more controlling and directive, and out of a desire to be protective, and maintaining a kind of trauma-informed strength-based approach, finding out about people's coping strategies. What are the barriers that have kept them from doing the things they want? What are their primary concerns? What are their priorities, and what do they want to have happen? And how do they analyze and weigh their risks? Eleanor Lyon and Jill Davies talk about this in their new book their initial book was Safety Planning with Battered Women. Their new book just came out a few days ago on this really strategic decisions that survivors have to make to protect themselves and their children. Again, asking about mental health and substance abuse coercion, we have several slides here, and I'm not going to read all of the questions. Some of them come from the survey that we did, and they will be online and available to you. But I want you to see some of the kinds of things. For example, does your partner tell you you're lazy, stupid, or crazy, or a bad parent because of your mental health or substance abuse coercion? Does your partner keep you from sleeping? We know that the impact of being up for many, many nights on end has on our mental health. Does your partner tell you that no one will leave you? Has your partner done things that make your mental health symptoms get worse? So think about this in the context of being someone who's experiencing depression or PTSD or has a substance abuse condition and is suicidal. Thinking about, discouraging treatment, interfering with treatment, and has your partner ever threatened to have you committed to a psychiatric institution? Has your partner ever told you that that you should kill yourself, or that he or she wished you would die? Has your partner threatened to commit suicide if you don't do or say what he or she wants? So again, those are not routine questions. They should be, and it's something we all need to factor in. And again, being able to respond and let people know that their partner doesn't have a right to control you. For someone who's experienced mental illness or substance abuse, there's so much shame and stigma associated with that. They may have internalized that and really believe, and other people may have consistently given messages that no one will believe them and they are really the problem. And finding people in your life who can validate that you have a right to safety and dignity is really critical. So again, suicide, this is something that you're all familiar with. One of the things, Patty, did you want to mention about resistance?
Resistance to the offender?
Yeah, when the offender is threatening to kill you.
Right. I do. Having worked in shelter and also on crisis line, the theme of resistance has come up over the years over and over and over again. And to give you an example of what I'm talking about, again, requires us to go back and think of suicide in the context of power and control dynamics, and that many times if a person is threatened repeatedly and the violence escalates, what happens is that a person may reach the point where the threats of homicide are overwhelming, or that there may be a homicide about to begin, and what happens is the individual may choose to often chooses and decides that you don't get to take my life. If you've taken everything from me up until now. So I've worked with a number of clients, for example, a case where when the husband told her he was going to use a weapon and end her life, she chose to inflict herself with a head injury. And of course, she was admitted as a psych patient, and it was not perceived as a resistance to a homicide threat. And what she shared with me was, he doesn't get to decide. He's taken everything from me. He doesn't get to decide. I could tell you 100 stories like that. And yet it often, if you don't screen for domestic violence and context, and if you don't look at this from a trauma-informed approach, in other words, what has happened that makes this behavior make sense? Because it's not always as simple as it's presented. These kinds of problems are even worse if you're working with someone who is not English speaking. I remember one setting where a woman was committed to an emergency department for assessment and was going in to the psych unit, but they decided to call in an interpreter, and the interpreter was a person who had experience in domestic violence. I remember the healthcare provider standing out there, and when the person who was talking to the survivor came out, they said, "So, does she have a problem with her mental health? Is she suicidal?" And his response was, "She has a problem with her husband. He is homicidal." And it's just like turning it around that way.
Thanks, Patty. So again, there's lots of ways to think about that, and this is also your slide.
Oh, yeah. So another area of concern, I think, when we're doing this work is to recognize the impact of substance abuse on safety. And again, being informed from work in the field, what I can tell you is it's not necessarily drinking or using that has the biggest impact on safety, but when there is a change in substance use pattern, when someone who is an occasional drinker starts binging, or someone who's been in recovery relapses, or someone decides to get clean and sober, just a change in pattern can be a red flag.
Okay, so thinking about treatment, and I know that we're getting close on time, so I'm going to highlight what's on the slides, and then you'll be able to read them, and we also have additional reading materials that we can provide to you. So thinking about safety and stability, which is both psychological safety and physical safety, reducing fear and isolation, and again, referrals to DV programs and the National DV Hotline are one of many ways to help reduce that isolation and to actually create safety. skills and resources both to navigate the world and for economic independence, and also to manage internal dysregulated states that may result from longstanding abuse. Again, trauma treatment that really understands the larger context of ongoing control. We talk about how do you heal while you're still under siege, and that also builds on those strengths and supports. Medication is an issue where you think about when we use medication and we don't think about is it safe and does it feel like something that's a choice as opposed to something that adds to the person feeling control. Documentation in ways that really highlight a person's strengths and don't place them in more jeopardy and actually contextualizes their symptoms in relation to the abuse. I think one more thing I want to highlight, let's see, is thinking about psychiatric advance directives. One of the things that we think about when someone has been hospitalized, and particularly if they've been committed, is who gets to make decisions for them when they're not in a place to make them for themselves. Mary Ellen Copeland, with her RAP tool, mentalhealthrecovery.com, talks about ways to indicate who do you want to make decisions, what decisions do you want to have made. But thinking about that in terms of IPV safety planning, who is the person, and is that person the person who's abusing you, and is there a safe person who can be making those decisions? And again, documentation, observations about the abuser are also helpful. Our colleague Denise Wolf-Markham talks about, well, sometimes collateral information from an abuser is helpful because they may incriminate themselves. So noticing controlling behavior can also be helpful to women in custody battles. So these are some of the elements of treatment. Again, these are really basically core principles of trauma treatment and trauma-informed care with attention to ongoing coercion and control. One of the things that's really important is thinking about the role of culture, community, and spirituality. And for communities where part of survivor's identity is very much tied to our family and community, that collective forms of healing are also critically important. Feeling part of a community, transforming a community so women, if they choose to leave an abusive partner, aren't displaced from the culture and community that's most meaningful to them. And Gwen may give examples of communities that, Indigenous communities that have been able to transform their entire community. One of the things about thinking about trauma treatment in the context of ongoing intimate partner violence, PTSD treatment targets specific symptoms and not this broader constellation of things that we've been talking about. Complex trauma treatment really addresses multiple domains, and the complex trauma framework talks about the many ways as human beings we're affected by trauma, how we think, how we feel, how we regulate our internal states and emotions, how we relate to other people, how we feel about the world. So all of those dimensions are addressed in more complex modalities, but they're harder to measure in randomized controlled trials. Also, most trauma treatment models focus on past abuse. There are a few models that don't, including yours, Nadine, and very few are designed for survivors who are still under siege. So again, it's like this emerging area in the field of domestic violence, intimate partner violence, of trying to think about what are the outcomes that are most meaningful to survivors from diverse communities, and what are the interventions that we can develop that address all of those domains in different ways and are individually tailored, and how do we begin to measure those outcomes. We also know that women experiencing intimate partner violence may be excluded from clinical trials, and some of the kind of more flooding exposure techniques may not be viable for women who are still under siege or in danger. So this is just a summary of the kinds of treatment that are out there, trauma-specific treatment. The most robust evidence is with PTSD treatment. We recently did a literature review with Chris Sullivan from Michigan State University, and there were 9 randomized controlled trials, and Nadine's was one of the highlights. The complex trauma treatment, there's less of an evidence base, but it's emerging as a way of thinking about how to have a developmental framework or relational context that embeds some of the evidence-based techniques, but also the PHIPSA office and many others are thinking about culturally specific responses to collective trauma that go beyond individual treatment modalities. So this is just a summary of what you can do. and I'm not going to read the slide, but it'll be up there for you, but it's really stretching to think about all the domains that the survivors who walk in our doors are dealing with, and thinking about how we work together so that we can address them in a more comprehensive way. So I'm going to stop there.
All right. Well, thanks to the two of you. And before we move on to our final presenter, I just wanted to remind everyone that we will be having a question and answer period at the end. But for those of you who are going to have to sign off, I've gotten a couple emails. Please feel free to type your question in the Q&A box at the you'll see at the bar at the top of your screen. There's a Q&A button, and you just click that and then type in your question. And I'll be asking our presenters to answer those questions at the end. So with that, let's move on to our final presenter, who is Dr. Nadine Kaslow, Professor, Vice Chair, and Chief Psychologist in the Emory Department of Psychiatry and Behavioral Sciences. Dr. Kaslow has experience in the link between family violence and suicidal behavior in the African American community, psychology education, training and credentialing, depression and post-traumatic stress disorder. President-elect of the American Psychological Association, she's also the editor of the Journal of Family Psychology. She is a past president of the American Board of Professional Psychology and former chair and board member emeritus of the Association of Psychology Postdoctoral and Internship Centers. She's received numerous awards, including the APA Distinguished Contributions to Education and Training Award, an APA Presidential Citation, and Emory University's Thomas Jefferson Award. So, Dr. Kaslow, welcome. We are delighted to have you here today and are ready for you to begin.
Well, thank you very much. I've really enjoyed the prior two presentations as well as the one the other day. And I have a long-standing interest in the link between suicide and intimate partner violence. So I am most appreciative that SAMHSA is prioritizing this right now. Let me begin. We can start with the first slide. I think we all have the reasons that we do the work that we do. Am I supposed to move these slides?
Yes.
Oh, I see. Okay. So first of all, I want to acknowledge the funding agencies that have supported this work, and most importantly, the women who have been in the Grady Nia project, our staff and the members of my team. We all have the reasons, I think, that we do the work that we do, and one of the main reasons that I do this work is that I had a patient who had a history of intimate partner violence who killed herself. I treated her while I was a predoctoral intern and postdoctoral fellow, and I want to read you her suicide letter to me, which I received the day that I took my licensing exam to become a psychologist. And so I really struggled with what did I want to do in my life. And I think it was either sort of quit or devote my life to trying to help women like her and make sense of what had happened. Dearest Nadine, by the time you receive this, I shall have joined the ranks of the deceased. The time for regrets and amends has passed, and it is time for me to take definitive action before I lose my sanity. I am truly frightened at times, for what I'm about to do is not reversible. However, I believe that taking my life is the only option left. Perhaps in eternal rest, I could finally sleep. I would welcome that wholeheartedly. As Odette had von Rothbart, that's a reference to Swan Lake, and she knew I danced ballet professionally. I have the voices, however, I cannot escape the curse. These past few weeks have been hell. The voices are calling me from far away, and now I must join them. After all I've tried for 2 years, that was the length of the therapy. Seems like 20, seems like 20. I would like to make clear at the outset that the closeness that existed between us was not a mistake on the part of the therapist. Rather, getting to know you and becoming attached to you has been one of the warmest, richest experiences of my life. Before I threw my journal away, it gave me great pleasure to relive the building of a trust relationship, to respect, to affection. You taught me and gave me a great deal, and no matter what type of hell I end up in, I will always remember and be comforted. From my vantage point, you and Sari was my co-therapist who was the psychiatrist involved, with her care. Gave me 2 years that I would not otherwise have had. That can only attest to your expertise as therapists. I'm saddened by thoughts of my kitties. My father will have them put to sleep, as was my other cat. Maybe we will reunite at another time and place. So, Nadine, I will bid you farewell, bereft of dignity, funds, friends, and my sanity. I have remembered things lately that are driving me over the cliff's edge, and so I shall plunge into the abyss. Do not mourn my passing. Remember the humor instead. I shall miss you, Nadine. Love. And so it's in that context that I sort of moved forward with a lot of the work that I've been doing since the early 90s. And the work over time has been termed the Grady Nia project, and Nia is a Kwanzaa term that means purpose. And so we really are hoping that the women who participate in our program will really find a new sense of purpose in their life, that they'll make much more of a commitment to living. We have served almost 1,000 women in this program and involved in this culturally competent intervention. So prior to actually conducting the intervention program, so we sort of heard about systems and strategies before, and I want to talk about a specific program now. We did a lot of research that examined the link between intimate partner violence and suicide attempts. And what we did is that we compared women who had were currently in abusive relationships or had been in the past year who attempted suicide versus those who had been were in abusive relationships and had never made a suicide attempt. And we were interested in what factors differentiated those two groups of women, because we felt like if we could identify those factors, that we could develop a psychosocial intervention program that most effectively targeted reducing the relevant risk factors and enhancing the pertinent protective factors. So what we found is that women who had more serious negative life events, had been abused as children, had more psychological distress overall, more depression, felt more hopeless, and had more substance abuse, and that was both alcohol and drug use, were much more likely, if they were in an intimate partner, violent intimate relationship, to attempt suicide. And one of the findings that I think is most interesting is it's not necessarily which risk factor you have, but it seems to be how many of these risk factors you have. So as you can see that the more risk factors you have, the worse, the greater the chance is you're likely to attempt suicide. So abused women with, say, 4 or 5 risk factors are 107 times more likely to attempt suicide than those with no other risk factors. So it seems like there's sort of a cumulative effect here. On the other side of the risk factor equation is the protective factor equation. What we found is that abused women who have a sense of hope, who are spiritually engaged, and some of our more current research shows that that's particularly those who have a sense of existential well-being, those who feel they have a certain kind of self-efficacy, who have more adaptive coping skills, they perceive to have more support, particularly from their families, as well as greater sort of social support in general from friends and the community, and who find themselves to be more effective in obtaining resources such as shelters or food. They tend to, even in the face of intimate partner violence, be less likely to attempt suicide. And so using this information, we over time devised an empowerment-based group intervention to reduce the risk factors and enhance those protective factors that I was just speaking about. One of the reasons that we selected a group intervention protocol to create was because of our findings around social support. And given that social support appeared to be, in many cases, the most critical protective factor that we found, we really felt like if we could provide social support in the context of the group, that in and of itself may have a very healing effect. And indeed, I believe that it has over time. So consistent with a standard randomized controlled trial. We do a pre-intervention assessment. People are randomized to either treatment as usual, which is actually an enhanced treatment as usual because they have access to our support groups and resource room, or to this empowerment group program, which is called the Grady Nia Project. And then they're assessed again at post-intervention and 2 follow-up times, which are 6 and 12 months after the completion of the program. So let me tell you a little bit about these groups. We have 3 to 6 women in each group. There are adults that are 18 to 64, and they've all attempted suicide in the past year and been in an intimate partner violence relationship in the past year. It was already mentioned we're one of the only studies that does not, or programs that does not insist that women be out of an abusive relationship. And I think that there are a couple of reasons that we've made that choice, and obviously there are pros and cons to this choice, and people from different perspectives are going to have different views on the pros and cons, but I just want to share with you where we're coming from, and it's a couple of places. Number one, as everyone knows, there's a lot of evidence that people who are in abusive relationships, even when they're out, are vulnerable to returning to that relationship or potentially another relationship. And so we didn't want people to feel like they couldn't be honest with us that that was happening. We really wanted to know, and we didn't want them to feel like their treatment was threatened because of that. So that was one thing, sort of taking that fact into account. The other thing, and I think this is something that I have gained a greater appreciation of over the years, is that I don't feel like I have the right to choose what's best for someone. So, for example, we treat a very low income, or some people would say no income population. And we have women in our program who essentially say, well, I can be abused 2 to 3 nights a month, really badly abused, but I have a shelter over my head for me and my kids. Or I'm not being abused, but I'm living on the streets with my kids. And I say to myself, I don't feel like I have the right to say, well, then you shouldn't be in an abusive relationship. It's better to be on the streets. And because shelters, at least in Atlanta, are extremely limited. The ones we have are quite good, but there's not enough space for them. They don't take, adolescent boys, and, the list goes on. And so I sort of feel like what we try to do in this program is be realistic about the lives that many of our women are leading. Every group is co-led by 2 therapists, and we find that to be really helpful because of the complexity of the situations that we're dealing with. At least one of the therapists is African American, again, as part of our effort to focus on being culturally competent, and at least one is a senior clinician. Just like we don't exclude people who have significant intimate partner violence situations, we also do not exclude people who have significant mental health problems. And we also have 2 helpers from the team who help with various aspects of the project. All of the women, those in our enhanced treatment as usual condition and those in the Nia project, have access to many other services. So this is really a full-service program in many ways. We run support groups. We started out with a weekly suicide support group and a weekly IPV support group, but now we have a spirituality group and a DBT group and a seeking safety group, and so they can access all of those groups. They can also get individual, couples, or family therapy. They have to wait until the 10 weeks are over in order to do that, but they might be getting that during the follow-up period. Psychiatric medication, consultation, and medicines are available throughout the duration. We have 24-hour crisis service. Rather than just telling them, go to your local emergency room if you're having a problem, we have a pager, the Nia pager, and one of us is on call at all times, and we field all of those calls. And oftentimes, for a lot of these women, having somebody from the team be the person available to them can help avoid a police call or or people needing to come to the hospital. We have an excellent relationship with our local police departments and their domestic violence units, and they really help us out in very respectful ways. We also have a resource room where we really can go with the women. There's a computer in there, and we can help hook them up with services. And we have very good relationships with our psychiatry department here. So in terms of each group session, the groups are 120 minutes at length. There's a check-in, a didactic part, and an activity, and then we do a wrap-up. Let me talk a little bit about the goals of the intervention. We really want to focus on the following parts. We want to focus on suicide and intimate partner violence, education and safety planning, and then in accord with the theory of triadic influence, in reducing risk and enhancing protective factors in 3 domains: interpersonal, social, situational, and cultural environmental. I'm not going to read through each one of these slides. I just want to make sort of the general point for each one of them of how this goes. We go about doing this. So we have a survival tip in each session that's sort of what helps them stay organized or focused in the session. And we begin with an introduction and commitment to safety. We've already heard the issues about the safety being so important. And we want them to develop a commitment to living, to working toward a violence-free family life, as well as to the group. In the second session, we provide as much education as we can about both suicide and intimate partner violence, and they create survival kits during this session. We heard about safety planning and the strengths of it and the complexities of it, and so we have them create safety plans not just for IPV, which is pretty common, but also for their suicidal behavior. And we work towards the creation of these, what challenges there are to using them, and how to overcome these challenges. And then we begin to focus the next series of sessions on those theory of triadic influences in terms of reducing risk and enhancing protective factors. So in terms of reducing the intrapersonal risk factors, this session really focuses on psychological symptoms, the relevant psychiatric services, and we teach sort of basic cognitive behavioral and empowerment strategies for reducing symptoms. We also want to enhance positive racial identity. Again, that's part of our effort to make this culturally competent. One of the activities is to focus on their strengths, positive things about themselves, and we have that go in their survival kits. In terms of enhancing the personal protective factors, this is where we really focus on hopefulness, problem solving, coping, and talking about techniques to enhance optimism. One of the things that we do is share images of African American heroines and personal female mentors. Some people will talk about their mothers, and other people will talk about people like Michelle Obama. And so really having a sense of strong black women that they can look up to. And I just gave that example. And we really want them to think about these strong women to help bring them a sense of courage and power and connection to other strong women. The next section has to do with reducing social and situational risk factors, and this has to do with paying attention to relational issues that may be stressful, associated with disagreements, helping them figure out what they can control in their relationships and what they can't, and how to support them in extricating themselves from abuse, whether that be permanent or whether that just be leaving the scene when things are beginning to escalate. Also talking about the impact of childhood maltreatment on their situation and teaching them ways to sort of communicate effectively, which obviously differs depending on the situation. We also, in the next session, we focus on enhancing their social and situational protective factors, and this is where we really spend a lot of time talking about social support, the value of social support, different kinds of social support, and how to access it. It's often something many of the women struggle with feeling okay to do, or saying that they don't really have any social support, and then we really help them identify ways in which they do. We then talk about reducing cultural and environmental factors. This has to do with negative messages about help seeking, about obtaining resources, and we have them do an exercise in which they ask for resources, and other women in the group help them figure out how to get the resources, and we invite people from the community to come in and talk to them about resources related to both intimate partner violence and suicide, as well as other things they may be struggling with. In terms of enhancing cultural and environmental protective factors, one of the things we found in our research is that it wasn't that women felt better and then they got jobs, but rather they got jobs and then they felt better. And so we really have begun to focus on community organizations that can help them begin to seek whether it be volunteer jobs or gainful employment. And then finally, we talk about a review and termination. Nobody sort of, quote, terminates from Nia, but rather they stay involved. They just typically switch their involvement, and we talk about how to do that over time. And there's always a little graduation party that we have, and one of the local restaurants donates food for that. And they also develop their own individualized aftercare plans, and they graduate. And for many of them, this is the first or only time they've graduated. Just to give you a sense of the sample, you can see over half self-identified as homeless. Many have children, although not necessarily living with them. Hardly any of the women are abused. At least over 50% are hardly any are employed. At least over 50% report currently being in an abusive relationship, and 80% said that they attempted suicide in the context of that relationship. What we found is that participating in this active culturally informed empowerment group program versus enhanced treatment as usual is associated at post-treatment and follow-up, or at post-treatment actually, with being less suicidal and depressed, less physical IPV, better hope, or being more hopeful and having better self-esteem, less alcohol use, being able to cope better and have more social support, and being more ready to change, at least vis-a-vis their intimate partner violence situation. We also found that when they're confronted with life stress, whether that be IPV or other things, when they're confronted with life stress, they tend to be less suicidal and depressed in response to that if they did in the intervention. We've also become very involved in the community in a variety of ways. For example, we have a spiritual care coordinator, and we've really helped connect with the concerned black clergy in the community. The community has reached out to us in many ways. For example, we have brought the women to Atlanta Symphony Orchestra performances. They give free tickets to the women in our program. The Botanical Gardens recently sponsored a Wednesday where we were allowed to bring all the women in the program to the Botanical Gardens for the day, and much to our surprise, when we got there, the Botanical Gardens paid for lunch for all the women in the program. So we've really gotten involved in the community. To support all of the things the women need, as you all know, grants from the government do not pay for the things our women need, and so we do fundraisers to support this. For example, at our recent fundraiser, we raised over $7,000. Every year we have someone whose name is Santa Nia, and she donates Christmas to all the women in the program. Recently, an anonymous donor gave us money to pay for public transportation tokens for all the women in the program between now and the end of the year, and also to pay up to $200 for 10 women each to pursue either getting their GED or getting vocational training. we have a newsletter, and we have a community advisory board as well. So I'm going to stop there, and I know that we need to take time for questions.
Well, thank you very much. So let me remind all of our listeners again that we have a Q&A box at the top of your screen, and I have a few questions, but let's see. Operator, if you wouldn't mind opening up for question and answers.
Why, thank you. If you do have a question over the phone, please press star then one. Please record your name clearly when prompted. We'll need that to introduce your line. Star then one, and 1 moment, please.
Chelsea, I wanted to introduce Gwendolyn Packard from the National Indigenous Women's Resource Center. Gwen's Lacontawan, Dakota. She's a program specialist with NIWRC and has many, many years of experience in both the DV advocacy world, running a DV program, and also served as executive director of the New Mexico Suicide Prevention Coalition. And he's on the line and available for questions. They recently did a webinar on suicide and suicide prevention, suicide homicide in Indian country. And Patty is with me as well, who's also available for questions on the intersection of substance abuse and domestic violence and suicide.
Oh, wonderful. Thank you very much for both of you additional people coming in and talking with us today. So, operator, do we have any questions on the line?
Getting in line. It's not here yet. So.
Okay. All right. Well, then let me ask one of my many questions. I think these presentations were wonderful, and I think I raised a lot of really important issues. But I'd like to hear all of you speak to some of the key elements of successful collaborations between suicide prevention and intimate partner violence professionals. And as we move forward with these collaborations, what would you all recommend that we focus on or that we keep in mind?
Well, hi, this is Marylouise. Others may have ideas on this, but I would just suggest, I think the collaborations would require obviously a mutual respect and inclusion. So I think we need to learn the two fields, sometimes overlapping, need to learn from each other. We've also found the collaborations, it's really important to understand programs' capacity to collaborate. So the importance of planning ahead, having collaborations be true collaborations where people plan together, commit resources together, implement together, rather than some of the collaborations we all pull off in the heat of a grant application moment, and which includes more something like signing each other's MOUs. So it would be an ongoing relationship. I believe that would really look at the capacity of both systems or organizations to support one another. The people in domestic violence programs have also been impacted by recent funding cuts, and I know mental health and suicide prevention programs probably have as well, perhaps to an equal extent. So I think looking at the resources available to support the collaborations and ensuring that both partners are supported in that work are critical to making them meaningful.
Carole, our work hasn't been focused on collaboration with domestic violence programs and suicide prevention, but with mental health and often substance abuse. And building on what you said, Marylouise, about making sure the resources are in place, it's also taking the time to really get to know each other in the ways that we understand things differently and the language we use, the perceptions we have, and building real relationships. Because often the people who are in systems who have long-term commitment, particularly if they've overlapped in other systems and can bridge or have had personal experiences that really bridge, can be very creative even with limited resources. So it's really finding those people in each sector who you can do that with. Folks in West Virginia, for example, the West Virginia Coalition Against Domestic Violence has started out having a mental health and DV group across the state for over a year before they just getting to understand each other's worlds before they started doing more specific work, which involved cross-training and consultation. Sometimes in some places where we've worked, co-location of services, so people really get a sense of each other's work or share some of that collaborative kinds of interventions. And also working together at the state level with coalitions and state mental health departments so that, you know, the people who are determining the funding and the shape of services can help support some of those collaborations.
I guess that I really agree with everything that's been said. And I guess the only other thing, I think this goes with the respect idea, is that there are many similarities between suicide prevention people and intimate partner violence people, but there are some real differences in kind of headsets about things. And I think rather than to get focused on who's right and who's wrong, I think it's really valuable to consider that both perspectives are useful and helpful, and they need to be navigated through, not criticized or just be viewed as incompatible. The other thing that we found really helpful is to have a community advisory board. And on that community advisory board, we have people that represent both communities as well as women who either currently are abused and or suicidal or who have been in the past. And that's really helped to keep us honest and on our toes and trying to figure this out better.
Well, thank you all. We do have a few questions in the question and answer box. Misty writes in, I work with an office of suicide prevention. As I've reached out to build partnerships with domestic violence agencies, I understand the barriers that make this challenging. I'm usually told to reach out to those working with the perpetrators. What can I do to help break down the collaboration barriers in our communities here?
I have to admit I'm not sure what I'm not sure I understand the comment about being told to reach out to programs that serve perpetrators. So not able to comment on that. I think some of the suggestions that were made earlier really get at that breaking down the barriers. It's that ongoing commitment to working together. And understand that really sometimes there are some different perspectives. It really takes an investment in understanding where we're all coming from in order to get through those barriers to collaboration. In my experience in working with cross-system collaboration, it sometimes is really helpful to focus on how would we handle a certain situation, and I'm not talking about a certain person perhaps, but a certain case setting, how would we solve a specific problem so that people can work together and often find that there's some common ground when people have interest in making sure that people are safe and secure that you may not find when you're talking about general principles of how do we differ and how are we the same. So sometimes getting concrete can I've seen in other settings, for instance, when we try to do collaborations across domestic violence and child welfare settings, that when professionals in those fields sit down and talk through together what a case scenario might look like if it goes well, that it really helps them to try to get on the same page because when it comes right down to it, they're all concerned about the safety of the individuals and families.
I'm also thinking, that state coalitions that do fatality reviews, that might also be a place. And I guess the question is if you're focused on suicide prevention perpetrators, that would make sense if you're thinking about for survivors as well. I think it's finding the people who are kind of doing that bridge and work in your community. Another time that this comes up is when there's been some of the coalitions that we've worked with, like in Pennsylvania in particular, have developed toolkits for communities when this comes up and the whole community is experiencing the traumatic effects of that, also of trying to help and not having been able to do. And so that's a tragic way to come together, but is one of the ways that happens.
The other thing I was thinking when I heard that question, this is Patty, by the way, in Washington State, we initially began a series of informal brown bag lunches between mental health providers, domestic violence advocates, sexual violence workers, people from the substance abuse arena, and began to develop relationships, have conversations, and not just talk about our differences, but identify themes that were common across all sectors. And that informal network became what's called Triple Play Connections, where we have all the groups from interdisciplinary professionals across the state having regularly scheduled meetings, times to do case staffing, to talk, with non-identifiers, and to really bring complex discussions where you can look more deeply at the issues to the fore. And this has been very helpful. And I think anyone, even with a limited budget, can set up a strategy of bringing people together, say once a month for a brown bag lunch that can lead on to more and more ongoing support. The biggest issue, I think, blocking collaboration is what was actually referred to earlier, when we get diverted by our differences rather than look at similarities. Now, for example, when we're looking at suicide, substance abuse, domestic violence, sexual assault, common theme in all of that is isolation. And when we as a community figure out ways to break isolation and reduce it, we're all supporting each other's work.
All right, thank you. So, Dr. Kaslow, I have a question specifically for you. This comes from Robin, and she says that she understands your project is for African American women. What services are available for women of other cultures?
So that's a great question. I think what other communities have done is to take our manual and adapt it in the ways that they see fit for their cultural group or community. All of our support services are open to women from every cultural group. It's just the quote research part of the project that we have the inclusion criterion for. But there's a whole debate in the world now about whether or not you take interventions and modify them or adapt them for a particular cultural group, or whether you create an intervention from a cultural group up. And we've chosen to do the latter. And so I think the generalizability of the findings is something that we, with appropriate modifications, is something that we need to figure out over time. But I do think that the general ideas of attending to both risk and protective factors, the value of a group format, I think that those things other people report are helpful across groups.
Okay, and I actually have another follow-up question for you from Kimberly. She asks about the protocols you use for enhancing victim safety.
So we have a variety of protocols we use, ranging from only having the woman in the room when we're talking to them. If there are women in same-sex relationships that are in a relationship with another person who reports being in a violent relationship, we don't put them in the same groups. We have sort of different passwords we use for people to connect with us to let us know, for example, there's something unsafe about the situation. We help people access free cell phones with sort of that 911 service on it. So we have spent a lot of time, obviously safety planning are things that we do to help support survivor safety. The security guards are very aware here of what the situation is, and if somebody comes in with a partner that there's any concern, the security guards will notify us right away, or they'll be available to us.
Okay, and one more follow-up question for you. This one is from Robin, and she asks about how someone can access the project manual for this particular project.
Oh, they can email me at nkaslow@emory.edu. And we do not charge for the manual.
Thank you for answering that. Operator Fran, do we have any on the line?
No, we do not.
Okay. Well, I'd like to ask the question to all of you. Isolation appears to be a really common thread between suicide and intimate partner violence. And could you all speak to some other common threads that really demonstrate the overlap between these two areas?
Well, this is Nadine. I think one of the big issues is sort of low self-esteem. Women and not having a sense of self-efficacy, that I think that people who are in abusive relationships end up feeling badly about themselves and get told bad things about themselves. And I also think there's sort of a sense of hopelessness that cuts across. And I think that there's also sort of anxiety and depression that are very common in both groups. On the other hand, I have been impressed by the strength, the remarkable strength of the women that we've been working with. And I think that sometimes those get ignored as things that are in common.
Those are good points.
I also think that the feeling of not having any resources, for people who are isolated, but where the social conditions make it really difficult to get out from under, or the cumulative burden of trauma. So all the kind of wearing down of resilience. And so I think the antidote of having access to social support and resources and being connected to other people and to yourself is, on the protective factor side, a common theme as well.
Other common themes, I think, are when you're looking at some of the key emotions that people express when they're experiencing domestic violence or sexual assault or feelings of suicidal ideation, often anger or pain or despair, depression, confusion, and certainly that notion of being overwhelmed. The notion of power and control in the case of having self-determination, if an offender is trying to take your life, as I mentioned earlier, people resist. And also, if an offender is losing power and control, they resist. And the resistance on the part of the offender may be suicide, homicide, and resistance on the part of the victim may be suicide if they're unable to physically or emotionally escape. The notion of safety, I think, is a key point. And whether you're a suicide prevention person or a crisis line worker, an advocate, or a substance abuse professional, all of us are engaged in making a plan that helps people reach their individual goals. A lot of times, in order to do a plan in any sector, you have to be aware of the risks from the other. So that a domestic violence safety plan may include how to recognize that an offender is at risk. It may include asking whether or not the partner has been using the car. I mean, a lot of the suicide, homicide issues that I've become familiar with through working in Alaska and Washington State often involve the use of the vehicle. And looking at that in safety planning, or what kind of threats are made, and to really recognize that if someone is presenting in any arena with depression, we need to screen whether or not domestic violence is occurring and whether we're talking to a person who's engaging in that behavior or experiencing that behavior. And on the flip side, if we're working in a domestic violence sector, to really explore what threats have happened and what behaviors might indicate, if not a direct threat, but a covert threat to suicide. And again, I go back to the use of the vehicle and other, where weapons. Yes, thank you.
The other thing, Patty, that you had talked about, it's not quite in response to that question, but I thought it was a really important point, was that a lot of times when an abuser threatens suicide, you want to talk about that?
Yeah, when you're talking about power and control dynamic, one of the really common threats that if you were an advocate working in a battered women's shelter, you would be working with women who are told, if you don't come back, I am going to kill myself. And this is such an overwhelming threat that could leave a person feeling significantly fearful. Often they still love their partner, they're worried, and it has the very real possibility that the person experiencing that kind of threat will go right back to the partner, and they have that choice. But what we have found really effective in Washington State and in Alaska is to really talk about how suicide threats are a form of communication, and they can be used in terms of coercion, but that all suicide threats need to be taken very seriously. And so we often encourage the people we're working with on the victim side to consider taking this seriously and help them to actually make a report to the local suicide prevention team in the community so that person can get the services and the help that they need, rather than put themselves in jeopardy by returning. Again, we don't tell people what to do, but these are options that if you are aware that this is happening, can be incorporated into your plan and the work that you're doing with battered women and survivors of sexual assault.
I think one of the other things that, Gwen, I don't know if you're on the line, but thinking about the kind of ongoing trauma from, in Indian country. I know Lisa Brunner was at a meeting we had earlier this week talking about, like during hunting season, people come to hunt and they don't just hunt deer, but that women and girls are at risk for predatory sexual assault, and there's no jurisdiction. The tribes don't have jurisdiction to prosecute sexual assault. But thinking about the other layers of issues that are ongoing that people don't usually think about that increase people's risk because the feeling of there's nothing I can do about this. Mm-hmm. And the tremendous kind of resilience and strength and people draw on, the cultural and spiritual and traditional values that really hold people together in the face of that and help them transform both their communities and the laws.
Hi, Carole. Yeah, I had my three top items that kind of popped out for me, and of course, jurisdictional issues were one of the major ones. And, right alongside that is our lack of data on these kinds of incidents that happen in Indian country. And yet every time we do a webinar or presentation on it, we always get tribal communities that are present that are talking about the number of incidents that have happened in their community of, the perpetrator killing his wife and children or relatives or whoever happens to be with her at the time that he attacks her, and then turning the weapon on himself. So we know that it's not uncommon, that it happens a lot. We just don't know to what extent. And that, along with the lack of jurisdiction and the challenges that creates in terms of investigation and prosecution and reporting, and kind of list goes on and on. And I think the other big thing that we notice in Indian country, too, is, we talk about guns or access to weapons, which is clearly there in every situation. It's on the danger assessment, and it's on a lot of the assessments that we do in suicide prevention. And yet we know that in Indian country, almost every home has at least one gun or rifle. That they're very much a part of our culture because of hunting, and almost everyone hunts in Indian country, so there's weapons are readily available in every home. And also, I think there's a lot of differences just about suicide in general between mainstream America and what we see in Indian country in terms of who's affected by this. Who's suiciding, in mainstream America, it tends to be white, middle-aged males, but in our communities, it's primarily our youth that are suiciding. That's where we see the largest numbers. So it's, there's a lot of differences that I don't feel have really been sorted out, and these are just kinds of things that always surface for us when we talk about this. And of course, the big one again is the lack of resources. Access to mental health care or to counseling, and then also, the economics in our communities, where we have some tribal communities where they've never experienced less than 70% unemployment there. So you can imagine a lot of the despair, along with the historical trauma and the historical trauma response that we see in tribal communities. And it just really, you know, we just have this this environment in our communities that just results in tragedy a lot of times.
Didn't you say that in urban New Mexico there was like one psychiatrist for 60,000 people who were living off reservation?
Right, right. And if you're fortunate enough to get in to see a therapist or a counselor through Indian Health Service, I can only speak for here. It could be very well different in other areas, but here you're only allowed 3 visits. So it's, you know, those are just to give you an idea of how lacking we are in the types of resources that we need to create that health and well-being in our communities, and why we really focus on peer-to-peer, which is, you know, kind of the backbone of the whole movement to end violence against women, is women helping women. It's very, very strong, and, you know, I think it's a real strength of all of our communities.
Well, I wish we could continue this discussion, but unfortunately we are out of time. I want to thank all of our presenters. I think this has been a really, really interesting conversation. We've gotten a lot of questions. I'm even being emailed questions, so I will be forwarding those on to all of you. And to our audience, on behalf of the Substance Abuse and Mental Health Service Administration Suicide Prevention Branch, I just want to thank all of you for participating in this webinar today and your continued interest in these very important topics. So, Fran, the fabulous operator, I think we are ready to finish.
Well, then, thank you, everyone, for your participation. As the conference is concluded, lines may please disconnect. Have a great weekend. Thanks so much.
Thank you.